I think we started off with two just wonderful presentations. Dr. DeYoung did this, and I knew he would, just an outstanding job of kind of giving an overview of what's happening and all of the current things that are going on in terms of healthcare reform and how they impact us and kind of relationship and connection to post-acute care. I mean, really a nice overview. And Dr. Ballon did a great presentation in terms of an example. So this is what value-based care and value-based payment looks like in a clinical environment when it's all integrated together, and it really is exciting. It really is exciting. So we're going to have a panel discussion now that's focused on quality metrics. And we're going to have three people involved in that. Dr. Vince Moore is going to lead the panel. And Dr. Moore is Professor of Health Services Policy and Practice and the Florence Price Grant Professor of Community Health at Brown University in the School of Public Health. He's also a health scientist at the Providence Veterans Administration Medical Center, and he's director of the CoStar Career Training Program. And we have two panelists that are going to present. You're going to do a little bit of a presentation, Vince?
I can do a little introduction.
Okay, okay. We have two panelists who are going to then present. Amy Leisenberger, did I get that right? Okay. Amy is a physical therapist, and she is the Senior Director for Outcomes Integrity at Navi Health. And our second panelist is Dr. Ann Deutsch. And Dr. Deutsch is the Senior Research Public Health Analyst at RTI International. She's also a research scientist at the Shirley Rhine Ability Lab and a research associate professor at Northwestern University's Feinberg School of Medicine. So thank you all for being here.
I'm getting up here because of the filming, not because I'd rather be up. So it's a pleasure to be here this morning. So we're talking about quality metrics and reporting. So is it the high road to value-based care or merely the next sort of step to disguise the fact that we are really a broken system? And I think that's relevant given earlier discussions. So most quality metrics are based on aggregations of clinical event data. Sort of, did a target person get a mammogram who needs the mammogram? Or a patient experience or an outcome, like a rehospitalization of a patient or patient's quality surveys. Some measures are also incorporate sort of structural factors like staffing or inspection results or so on and so forth. And all of these then are the basis for quality metrics. The modern purpose of these metrics is really to facilitate patients' choice or to more directly reward or penalize a provider financially, provider or a healthcare plan. So ergo, that's sort of value-based care. While providers and even MA plans are rated on dozens and dozens of generally non-correlated measures to rank or pay or penalize, one needs a single composite measure. And that's essentially what a lot of the work that we understand about quality metrics is. There is growing evidence that these choices that patients make are actually influenced by these composite rankings. People are sorting on at the margin. It does make a difference. So we'll have two talks this morning that will address the efforts to deal with two critical challenges in current provider-specific composite quality metrics. First, A.B. Liebensberger will discuss an alternative quality rank, amongst other things, an alternative quality rank composite for sniffs that's more focused on post-acute care than the current CMS 5-star nursing home compare measure, because the purpose of SNF care, that is, for what's provided, is heterogeneous. And so you have a single composite, but it serves heterogeneous purposes, and that means the composite is not in and of itself as essential or as effective as it could be for subpopulations. So this is only one example of the complexity of the one-size-fits-all ranking system that we currently are grappling with and dealing with as we move forward in this process. And next, Ann Deutsch presents her latest work with CMS trying to use common measures of function as outcome states that we, across different care venues that we would like to be able to compare, because people are making choices about these different venues. And so how to have a comparable measure of function is really critical to that. And so we'd like to be able to help patients and providers manage and even improve the transitions in care that they experience, because it's ultimately going to require a whole new kind of metric of composite measures across venues of care, which would be applicable clearly for ACOs, who are responsible for the whole bundle, or MA plans, who are responsible for everything, as it were. I wanted to assure you that these metrics really do matter. So let me give you an example from our current work that we're doing here at Brown. First, in the world of Medicare Advantage, MA members consistently go to lower quality hospitals, home health agencies, and skilled nursing facilities using the current 5-star ranking system. On the margin, in every different place, controlling for choice. And at least for sniffs, which we've looked at carefully, it really does matter. An individual patient adjusting for all of their choice set and all kinds of other options, going to a poor quality place relative to a better quality place, will have worse experience. So the ranking systems and the composite scales that we're working on, probably still in the alpha versions of what will ultimately be, really do matter. And so the work that Amy and Ann will be talking about has to be thought of in that sense. So thanks, Amy.
First of all, thank you for inviting me. I have a confession to make. I am not a researcher. I, though, consider myself to be an applied researcher. And the fact that what I'm going to be sharing with you today is how we have taken the data, turned it into information, so that the clinicians in the field can actually somehow achieve the outcomes that we are trying to measure. If we don't give the clinicians a tool to change all of this data into information and to be able to apply that on every single day, just as Dr. DeYoung said, if we don't make smarter clinicians, then we're not going to get any of the outcomes. We've been working on this for the past 20 years, what I'm about to share with you. I work now for a company, the name is NaviHealth. Its precursor was a company called Senior Metrics. Our challenge, what we wanted to do, was to be able to provide the clinicians with a tool that enabled them to use data in order to look at what will my patient be able to achieve. Through this journey, what we've been able to do is not only assist clinicians with changing their behavior patterns, augmenting and enhancing their ability to make these decisions, but also we have changed the way in which they have delivered their care. Along the way, though, we've also amassed a huge database. And from that database, we are going to be able to use more information in order to drive the research capabilities of the industry and of our country. What we do is, we are a company that is a case management company, but we are different in that we do have our clinicians use data for their decision making. What happens is that we have feet on the ground in the hospital, in the skilled nursing facilities, in the IRFs, in the LTACs, to help drive that patient's whole course of care across the full care continuum and talking between the silos. Not just simply looking at one silo and then transferring the patient over and then they do their own thing in the post-acute arena. We've been very successful with this simply by giving the clinician information based upon data that is constantly fed by those records that we are constantly feeding into our database. As you can see, we're across the country now. We are amassing data faster, faster than we ever have before. We work with ACOs, we work with managed care, health plans, hospital systems, and we also work with BPCI. So we now have a database that composes of fee-for-service and MA, just to give you an overall view of that. We work within a very traditional system of case management, guys. We go from the acute care setting, taking them either home to the SNF, and then from the SNF back to home or whatever other post-acute care site there is. But the beauty of this and the difference on this is that we interject along the way points at which they have to assess, look at the data and say, what have other patients been able to achieve? So instead of Amy going in and saying one thing based upon my assessment, and then an occupational therapist goes in and says something else, and our physicians say even something different, what we've been able to do is to provide the clinicians and the teams at each point along this way in the hospital, in the skilled nursing facility, and also in the IRF and in the LTAC, ways to measure the patient and then provide them with a guide going forward. Never before had it been done 20 years ago. These days, we are having more and more people who are actually now, more and more companies who have evolved, who are now doing the exact same thing, but simply using different algorithms, different methodologies, and using their own databases. But the beauty, once again, is instead of guessing where the patient should be, we're now using the information, giving that to the clinician based upon the data that we've amassed. What did we use? First thing that we knew 20 years ago is that in post-acute arena, as you know now, in the post-acute arena for the senior population, that which drives outcomes, regardless of whether it's where the patient is discharged, what the functional gains are, what the caregiver needs are, it was function. We started off utilizing the functional independence measure, and then we adopted, back in 2002, the AMPAC, which allowed us to hit the ceiling instead of being limited at the FIM level of 150 feet, timely, safely, without any assisted device. Now what we're able to do is go into the community and we can measure our patients all the way from the bedbound status all the way up to running 5 miles without any difficulty. What that allows us to do is to measure across our full care continuum and to track the patient across the full care continuum within one functional measurement tool. What we also did, again, we have to work with the clinicians so that it makes sense to the clinicians. If we don't get down to that level, you are not going to get the outcomes to measure. We're going to stay where we are. If we can't change their behavior, if we can't change their practice patterns, we are not going to see any changes whatsoever. So we made the crosswalk, and we showed, this is our crosswalk into the traditional min-mod-max nomenclature so that the clinician very quickly could look at these numbers and say, okay, now I understand where you're coming from. If we don't make that connection, the clinicians will never use it. Very quickly, the methodology. Methodology is quite simple, guys. We're working on a different one as we speak. We're always looking at different algorithms, methodologies. We now have a much more robust data science team. We started off with only 2 of us. Now I've got some mathematicians that I'm very pleased to work with and some statisticians. That's another thing, guys. I know enough statistics to get myself in trouble, so please, if there's any higher level, I'll have to refer you elsewhere. But what we were able to do, we had 2 goals. One, we wanted to have a measure that was, yes, a gold standard measure. So what we did is we went into our database, and we do now have about 3 million records. That 3 million records includes acute, home health, SNF, LTAC, IRF, the full care continuum. We wanted to establish, for the first top, we wanted to establish a best practice comparison data set. We didn't want to just say, clinicians, practice towards the average. No, we wanted to have them practice towards the best practice. So what we established was, we went into our database and we selected the top 20% of our highest performing facilities. How did we determine that? We looked at not only, once again, going back to value-based, we looked at the efficiencies that they did, but first and primary, were they able to achieve the functional outcomes that we expected and that we could track and that we knew that should have been expected? And I'm going to show you a little bit about that later on. So we selected, first of all, a best practice data set, looking at efficiencies, length of stay, and we're talking about sniff right now, length of stay and your discharge function. Then what we did is we said, what are the variables that we want to match on? We ran a regression analysis, and what we found was that the top 3 variables that always floated to the top, as you guys know, the first one was admission function. That in the post-acute arena was driving the course of events primarily across the board. Second of all was what we call a medical complexity, which is a measure that we use for prior level of function. And then third but not least was impairment group. Each one of the ICD-10 codes is mapped to an impairment group. Then it was a simple matching. We took the top 3 indicators for that patient, we assessed the patient, we matched to our best practice, and that was what the clinicians and the teams used. Those averages were used in order to plan their care. What you have in front of you, did we pass those out? What you have in front of you is an example. It gets a little bit small here. Actually, you are seeing this before. Many of our clinicians see this. We are rolling this out next week. We have done a facelift on our tool. On this tool, what we knew that if we got clinicians and teams knowing or getting kind of a view of what have other patients been able to achieve. If we could get them into this, well, let's give them a crystal ball, and what has happened to other patients, then the team meeting no longer becomes, Amy, what do you think? Judy, what do you think? Dr. So-and-so, what do you think? We now have a true indication of what others have been able to achieve. And so it's very simple. When you put data and information in front of the clinicians, in front of the team, they will follow that after a while. I'm not saying that they enjoy it at the very beginning, but what will happen is that they soon see that, wow, this is a great tool to not only enhance and augment what I'm doing, but also to be able to, as we have said before, is, hey, I had a gut feeling that that was going to happen, and look, this is actually what others have been able to achieve. So let me show you just a couple of things that I want that the clinicians now have that we never had before and that many of the clinicians right now still do not have. If you look at the top right, what you will see is that on the top right where it says patient demographics, that is your patient, and that is each one of the patients are assessed upon entry into the hospital and then once again upon the sniff. In the hospital, the question has always been, is it best to send them home or to a community environment, or is it best to keep them into an institutional or a sniff environment? So at the assessment of the patient, we assess them using the AMPAC. We use the CAT version of the AMPAC, and we will get 3 domain indicators. We have changed these, for those of you that do use the AMPAC, we have changed these from a 0 to 100 scale because it's just simpler for our clinicians to understand that. What they are able to do now is, if you look at I think you'll see more on the handout that you have, we are able to look at where they are in function. If you notice at the very top, you have a 37, 34, 76. We have converted those into the min, mod, max right underneath that. The clinician already knows where they are on all the domains. Right underneath that, we have been able to assign a non-skilled caregiver assistance level. So what is the next question in the hospital? Well, if I go home, how many hours of caregiver assistance am I going to need? Non-skilled caregiver assistance. So we've turned this once again into from a guessing game into one in which you can use the data and immediately, every single day with every single patient, use what you guys are researching and put it into the hands of the clinician. Once that assessment is done, if you notice on the next two levels, you will see where it says home health, and then it says sniff outcomes. This allows the team to say, wow, given this group of patient characteristics, what has happened to those that went home with home health, and what happened to those that went to the sniff? You've never had that before. It's always been, well, Amy, what do you think? Amy, do you think they should go here? Should they go there? Now what we're able to say is, well, you get comparable outcomes in either one or the other, so our thing is, if you can get comparable outcomes and you can provide the medical care in the home setting, then why not home? There is less guessing. I am not saying, and we will never profess to take away all of that, but we've taken once again, the first time that I have seen as a clinician, the ability to put this into the front of the clinicians to say, this is data. Don't be scared of it. It provides you with more information, and let's start making our decisions based upon that. What it also allows us to do at the bottom is provide the patient and the family. We are now giving them data. We're now giving them information to say, if you do go to the sniff, no ma'am, I'm sorry. AARP is not right. You do not get 100 days. You only get those days in which you are qualified for skilled care. And so you'll probably, Mrs. Smith, you'll probably be in the skilled nursing facility only around 12 or 14 days. And at that time, we know you will probably be around this level of assistance, and we can provide you and we can anticipate that need. Anticipating, guys, when you know and can set expectations based upon data, you can rely on that so much more than what we had to rely on before, which was my memory and your experience versus my experience. If we can set the two key things here are setting expectations within the team and within the family early. Once you do that, then you will get the outcomes, and those outcomes you will be able to measure. But if we don't get this data to the clinicians, then it's going to be all for naught. This is our sniff. Outcomes predict. Once again, when they get into the skilled nursing facility, we use these outcomes to help us in the interdisciplinary team meetings. Many of you have participated in those possibly in past lives. Whereas before, what did we do? We said physical therapist, occupational therapist, nurse, what do you think? Now what we're able to say is, given this patient population, given a matched population based upon function, medical complexity, and impairment group, what have they been able to achieve? So why can't we get there? What are the barriers? It changes the whole dynamics. So what we have been able to do, and I'm going to show you that now, is we have been able to change behaviors. We've been able to change practice patterns, but not compromise outcomes. And that has been what we have watched from the very beginning. Our value component has been the value component from the very, very beginning. 20 years ago, before even value-based had a definition, we were working on making sure that as we improve the efficiencies, we did not compromise the outcome. This is our dashboard. When we look at the dashboard, we call it a severity-adjusted dashboard because it allows us to look at a couple things about the sniff. The next question that Dr. Moore asked is that, well, how do you know which sniffs are best? How do you know those that provide you with the best outcomes? Not compromising their outcomes, but not compromising their quality outcomes, but still giving you the efficiencies that we know have to drive healthcare at this point. This is how we know. What we put together here is, if we look, I'm going to give you a very quick example of Jefferson Avenue and Mercy Court, two skilled nursing facilities, and let's look at what we may have assumed at one point and now what we know. If you look at Jefferson Avenue and look at their length of stay, it's 12.7 for those 105 patients, and Mercy Court is 85 for the 14.2. So you're thinking, looks like Jefferson Avenue, they're probably more efficient. They're lower length of stay. But then let's make sure about quality, right guys? So we go over to discharge function, and still they're looking pretty good. Geez, they got a 44 on average at discharge, and Mercy Court only got a 33.6. Where am I going to send my daddy? Obviously, I'm going to send him to Jefferson Avenue. He gets home faster, and he gets a higher function. But hang tight. What happens, though, if you compare this to that same matched patient population that I talked about, where we pull them out and we match them to those top 20% facilities? The story changes very quickly. Now look at your target length of stay for Jefferson Avenue. Actually, they had all total knees. They were supposed to have an average of 10.5, and in actuality, they were 21% over in their ideal, severity adjusted, best practice target. We call those the target. Right? If we go back, though, we still have a question. They were still making better gains, right? So maybe it's okay for them to stay longer if they were making better gains. But be careful on that one also. Whenever you look at Mercy Court, actually, that 33 wasn't too bad, because when we severity adjusted, they had all lower functioning patients, and they were primarily neuro and CVAs. If you do not, this is the type of information that before, all the bean counters would go for 14 days, 14 days, 14 days, regardless of your patient population. Now what we're able to say is, hey, you may have a patient population that warrants a 21-day length of stay. These are the types of things out in the business world that we are having to contend with, how we are trying to use data in order to, one, get better outcomes from our providers, but also change behaviors at the level of the clinicians. So now what comes is that actually Mercy Court is the place to go, and if we look over here at therapy hours per day, yes, we collect on every single patient the minutes that those therapists spend with their patients. And what happens, to tell the story here, is we make sure that we follow the therapy hours per day, because guess what drives outcomes? Usually, outcomes are driven by not only the therapy hours per day, but also the length of stay. So both of these, what you can see now is we are trying to take the information and really try to instill value-based care in an industry right now that some of them know about it, they've heard about it, they're a little bit afraid of it, and with RCS-1 and all of the payment plans coming in, people are starting to ask, how do we get there? How do we get those outcomes that we're all measuring? This is the way that we are attempting to do this. You can do this 9 ways to Sunday, but this gives you an example of what we are doing out in the field in order to extract better outcomes. This is what has occurred. It's a very simple, again, I didn't want to put anything up here that I could not explain. So we did a simple scatter plot here. This was actually Denver, Colorado. Before and after, we simply gave them data to make decisions with. So on the horizontal axis, you've got sniff days, and on the vertical axis, you've got points of improvement. If you notice, if we just give the teams good and valid information, what will happen? Look down at the bottom. Your functional gains are not compromised. But what happens is that all of those outliers, what we're able to do is we're able to reduce the variation of practice and utilization. There is the data, there is the value component for efficiencies and cost that we who are in the field, we have to address also. It's how you get your customers. That's how you're able to justify what you are doing, but we did not compromise the outcome of the patient. I want to show you a couple of other very simple slides for you guys to look at. All we're tracking on this is we're looking at the variance. Remember I told you there was a variance between the target and the actual? We now look at variances. We do not look at length of stays anymore because they do not tell us anything. What you will see here, this is a very, very typical pattern that once the clinicians out in the field adapt and adopt to and accept and embrace the ability to use data to drive their decision making. The top blue, that's your length of stay variance. And yes, you see a very, very quick slope down as they improve their efficiencies. But all of the lines down here, your discharge score variance, your 30-day readmit rate, they are steady, steady, steady. We see no decrease. We see no compromise in your discharge variance or in your 30-day length of stay. Sometimes, like on this one, we'll see a slight increase in your therapy hours per day. But for those of you that are into rugs, it's all within the very high. We don't see that the ultra high adds any component whatsoever overall whenever we're looking at outcomes. This is just another way of looking at it. I'm glad to see that we talked about CJR. I pulled out the total knees and total hips. Once again, you've got all your quality components on the left-hand side, steady across the board, and what is improving across, from one to the other. And I could do this for neuro, I could do this for pulmonary, cardiac, any of the others. What you will find is that as you improve your efficiencies to a point, you will see that the quality outcomes are not compromised, are not changed. And just to give you an idea, because some people will ask this, what is a 22% difference? Look down at the bottom. That took us from a 13.6 day down to an 11 day stay on average. And if you look at, here's your total hips, again, very, very same patterns that you will see here, but I could do this for almost all but neuro and CVA. They have a little bit of a different adaptation than what ortho does. But again, you've got a homogeneous population here. This is what you'll find time after time. So as researchers, and again, putting myself hopefully as an applied researcher, this is where the rubber hits the road. This is where you say, how do you take all of this great information, how do we turn that into knowledge for our teams out in the real world? How do we take that into the business world? That's where it is, guys. And how can we enhance the whole industry by using your information, but making that transition over to the clinician? Is that?
Thank you very much.
Thank you.
Perfect time.
Okay, thank you. So I'm Ann, and again, wanted to thank the committee for inviting me to present today. I'm very pleased to present some of the work that has been going on related to functional status measurement under a CMS contract. And I will building on what a lot of has been talked about today. So the Impact Act has been mentioned. I'll be talking about that a little bit. And there's, I guess Ken started out saying that there's been so many changes. It's an exciting time. I totally agree with that. I think part of that, there's been so many changes, it's hard to keep up with things. And so part of what I wanted to do today is to give a summary of kind of the evolution of what's happened in the past few years, especially related to the Impact Act and functional status quality measures, and talk a little bit about the data related to that. So just a disclaimer and disclosure, so the statements contained in this presentation are those of myself and do not necessarily reflect the views and policies of CMS. Funding for this project comes from both CMS as well as RTI International. So just in terms of background, there are really two laws that kind of have shaped this work. The first being the Affordable Care Act from 2010, which implemented a quality reporting program for inpatient rehab facilities and long-term care hospitals. Following that, the Impact Act, which you've heard about, so Improving Medicare Post-Acute Care Transformation Act of 2014, and that established the Skilled Nursing Facility Quality Reporting Program and also required the collection of standardized assessment data for patients receiving care in long-term care hospitals, skilled nursing facilities, home health agencies, and inpatient rehab facilities. So in terms of the standardized patient assessment data that is part of the IMPACT Act. The idea behind that was that this data would enable the collection of uniform patient assessment data across these post-acute care settings. It would allow the ability to understand better the quality of care and potentially improve outcomes. It would allow comparison of quality and data across post-acute care settings, and also would provide the opportunity to improve discharge planning, improve the exchangeability of data because of interoperability, and would also improve potentially the care coordination. So the IMPACT Act was passed in 2014. I think it was signed October 6th. And pretty quickly after that, CMS had the responsibility of implementing measures covering some of the topic areas within the IMPACT Act, one being the functional status. So specifically, the section on functional status for the IMPACT Act spoke about the secretary had to specify a quality measure in satisfaction of the domain of functional status, cognitive function, and changes in function and cognitive function. In order to meet that deadline, CMS implemented a process measure. And again, in part, this was because the IMPACT Act got passed in late 2014, and basically they had to work through putting through regulation, a proposed rule, and then having public comment opportunity and adopting or finalizing after reviewing public comments. And so at that time, there had actually been a lot of work, and Gerben had spoke about the Deficit Reduction Act, so there was the post-acute care payment reform demonstration that had happened between about 2006 and 2012. There was also a project that was funded by the Assistant Secretary for Planning and Evaluation that said, how do you take what we learned from the post-acute care payment reform demonstration, functional status data, how do we turn that into quality metrics? How do we take data and then analyze it such that it would actually measure quality of care? So, and there had been actually a CMS contract that I worked on as part of my RTI role, and we had started developing some outcome measures for the inpatient rehab facility settings, and we'd also worked on a outcome measure for long-term care hospitals, and we had also developed a measure, so this was pre-IMPACT Act, we had developed or we're working on a measure that was basically a process measure requiring the collection of standardized data elements. So it was kind of, this was before the IMPACT Act. And so given the short time frame between the IMPACT Act passage and CMS needing to meet deadlines, the first quality measure that actually was adopted in some of the post-acute care settings was actually a process measure, and it was a modification of this long-term care hospital process measure that required the collection of admission and discharge data. And it also required that a goal be documented for at least one area of self-care or mobility. So it was a pretty simple measure in some ways, but again, a way to get started into the IMPACT Act. So on the slide you see, if you're interested in reading regulations, there's plenty of links here. I do think there's a few people here who do read regulations quite carefully, but probably not many. So anyway, so that was the initial quality measure that got implemented, and the quality measure is basically, are you collecting the standardized assessment data on admission and discharge, and do you have at least one goal for each patient in the area of function? And by the way, that was implemented for inpatient rehab facilities, skilled nursing facilities, and long-term care hospitals in the same year, and that was in the fiscal year 2016, proposed and final rules. So that was in calendar year 2015 that those got finalized, and then Home Health just recently put that in their rule that was published last year. So that's kind of new information. So now I'd like to speak through each of the different settings and kind of the different measures that are currently adopted into the different quality reporting programs. So for the IRF quality reporting programs, as I said, we had worked on these 4 functional outcome measures that really got started with that ASPE contract, and then we spent a lot of time on the CMS contract working on those measures. We had several TEPs across the ASPE project, and in fact, many people in this room were on some of those expert panels. And so we ended up with 4 outcome measures. They use the same items. All measures are risk adjusted. The first 2 measures look at change in function, the first one being change in self-care, the second being change in mobility. And that is the way a lot of people in the inpatient rehab facility and skilled nursing facility industry have kind of looked at function, using looking at the difference between, you know, where a patient started and where they ended up. In some work that I had done a few years ago, we had created some fictitious report cards, went out to senior centers and asked normal people if they had to choose a place to get inpatient rehabilitation or skilled nursing facility care, you know, would they find information about change in function useful? We had a change in self-care, change in mobility. And many consumers, as you probably would not be surprised to hear, had difficulty understanding what a change in function really meant. What did 20 units mean? And so as we were thinking about the quality measures and thinking about this needing to be publicly reported at one time in the future, and that it would be important for consumers to be able to digest and use the information, to Vince's point earlier. So what we did was we created these 2 change measures that the professionals were used to seeing, and then we took the same data and aggregated the data differently so that we are looking at information that might be a little bit more digestible for consumers. And so these 2 discharge self-care and discharge mobility measures basically report the % of patients who meet or exceed a benchmark. So that is something that many quality measures have a numerator denominator, and this is basically the same approach. You have an observed discharge score for each patient is calculated for self-care as well as mobility, and then these we use our risk adjustment variables to predict an expected score for those patients based on their diagnoses, based on their clinical condition, comorbidities, many factors. We actually have, I think, about 70 risk adjusters across both of the measures. And then, again, you get this % of patients who meet or exceed a benchmark. So those quality measures were actually adopted, as I said, through the fiscal year 2016 final rule, and the data collection started October 1, 2016. The data collection includes the function items as well as the risk adjuster items. For the long-term care hospital quality reporting program, CMS adopted 2 quality measures, and one of them is focused on change in mobility for patients who require ventilator support at the time of admission. And there is a note at the bottom of the slide that this was actually required through the Pathway to SGR Reform Act of 2013. And so basically we had a deadline and we had to get that and proposed and rules for comment pretty quickly. And then the original process measure was actually implemented also in the long-term care hospitals. In the skilled nursing quality reporting program, again, this is one of the newer programs, and in last year's rulemaking cycle, CMS proposed and finalized the 4 outcome measures that were adopted for the IRF quality reporting program with some modifications. So we built a risk adjustment model based on the data. Not all of the same risk adjusters were important for the inpatient rehab facility patients and skilled nursing facilities, and so there are some slight differences, but in terms of like the items and in general risk adjusters, many of them are very similar. So the data collection for that starts October 1, 2018. So that's this year. Just in terms of the standardized patient assessment related to the IMPACT Act, so as I mentioned before, CMS has proposed and finalized through rulemaking for each of the 4 settings the collection of some of the Section GG functional status data. I know CMS gets a lot of questions. I get a lot of questions about, which items are on which data sets and why are they not all the same. So the answer to the second question is that CMS adopts item onto the data sets based on quality measures and the standardized data elements that are finalized through rulemaking. And so at this point, this gives you a summary of at least the self-care items. And so you can see that eating is the same across all of those settings, and it has been finalized in all those settings. The one of the areas that you see a difference, wash upper body. So in the original testing of the CARE tool and the post-acute care payment reform demonstration, which was part of the Deficit Reduction Act work, there were 2 items related to bathing. One was wash upper body, which was meant for more kind of acute care settings. And so you can see that one is actually on the LTAC care data set at this point as part of the items in the process measure for long-term care hospitals. In the other settings, the shower bathe self, which is about washing the entire body, is on the other 3 settings. The dressing items were not, there's not a self-care, change in self-care or discharge self-care measure in the long-term care hospitals, so you do see fewer items on that data set. And just to, I guess, reinforce the dates, so the IRF-PI, I'm speaking about the October 2018 data set because that's been finalized and to be implemented October 1. These items were actually on the 2016 data set. The minimum data set, this reflects the 2018 version, October 1, 2018 implementation. The July data set for LTAC, which is getting implemented shortly, but these have been on that data set since 2016. And the OASIS data set will become effective January 1, 2019. You see here most of the mobility items, and so again, you see LTAC is a little bit different because some of the more challenging activities, for example, picking up an object from a standing position was not put into their quality measure for change in mobility. And then on each of the data sets, this was part of the process measure, the original measure implemented through the IMPACT Act. There is a gateway question asking about whether the person uses a wheelchair, and if they do, their ability to manage wheeling 50 feet with 2 turns, 150 feet. We also ask about the type of wheelchair used. If you're not familiar with the items, just wanted to show you what the data set actually looks like. This is the IRF-PI version, and so the data set has a column for the admission performance, a column to put a discharge goal, and then the definitions are all on the data set. This is the rating scale. Again, I just took IRF-PI as the example, but they are all the same across all the data sets. So it's a 6-level rating scale going from 6 independent to 1 dependent. In the situations where the activity does not occur, that means that the patient didn't perform the activity and a helper did not perform the activity for the person. We are able to get from the clinician the reason why. So was it that the patient refused? Was it that it was not applicable, meaning this was not something that the person did even prior to their current illness, exacerbation, or injury? And so we get the sense that it's a long-term situation that's been happening for the person. For example, maybe somebody's had several strokes over time and they have not been eating by mouth for 3 years. And so we would be able to get that information. There's a code 10, not attempted due to environmental limitations, because we do have things like car transfers and walking on uneven surfaces, and not everybody is able to implement those things in every setting. And then finally, there's the code that is most commonly used when an activity doesn't occur, which is 88 not attempted due to medical condition or safety concern. So I did want to share some data with you. This is, I think, one of the first times where that these data are being presented. The data, as I said, has just recently been implemented and started to come in. And so I did want to share what I could with you. So for the IRF setting, I have 9 months of data, just to give a bit of context in terms of the timing. So as part of the IMPACT Act and Affordable Care Act, CMS has the data come into CMS through the data sets. CMS then provides review and correct reports to the providers, and so if the provider finds they may have had some errors in their data, they have an opportunity to correct that. So there's a time between the end of a quarter and a 4.5-month lag, actually, where the facilities are able to correct their data, and then the information then becomes frozen. So I was able to access 9 months of frozen IRF data before I had to submit these slides. So the data represent Medicare Part A, Medicare Advantage data, and it's about 369 patient stays. LTAC, we have a year data because they implemented a little bit earlier, and so that's about 123,000 patient stays. SNF is a fairly large number with over 1 million, and that's Medicare Part A. That's 12 months of data. The last quarter is not frozen of that data. So here is the data. So I guess what I wanted to show here is just, one item on admission. So this is eating. And you can see for skilled nursing facilities, the first row is the admission data, and the second column is the discharge data. The next group of data is the IRF data, admission, discharge, and then LTAC. And what I have in these 100% bars is basically the blue is the level 6, so that's independent. And so you can see in the skilled nursing facility, we had, about 27% of patients who were independent, level 6 is independent, with eating on admission, and that increased to 56% by discharge. In the IRF setting, there were 29% of patients on admission who were independent with eating, and that increased to 66% by discharge. In the long-term care hospital, 23% on admission independent with eating, and 39% independent by discharge. So as you can see, if you want to look at those a little bit more carefully, there's quite a different distribution across the settings, and of course it changes quite a bit at the time of discharge. Another example, toileting hygiene. So this is another self-care activity, a lot more challenging. And so you see very few people who are independent on admission. And so in the skilled nursing facility, was 4% of patients on admission went up to 36% independent by discharge. In the inpatient rehab facility setting, 3% up to 43% by discharge. And in the long-term care hospital setting, 10% on admission up to 24% by discharge. You can certainly see, again, the level 1 is much more common in the long-term care hospital setting as expected relative to the other two settings. And I just, as kind of wrapping up, just wanted to mention that there's a lot of work that we spend working on risk adjustment models. I wish I had another hour to talk about that, but there was an article that we recently published focused on our risk adjustment model, our methodology, our thinking, and how we came up with our modeling, and that was published in Medical Care fairly recently, last year. So a lot of the information actually is available publicly because these are NQF endorsed measures. And so there is a lot of information that is out there. It's kind of hard to maybe find and digest all of it, but we do put a lot of thought into the work. And one of the nice things about doing this type of work is I I'm able to get a lot of input from a lot of very invested stakeholders, which is really great because, in a research project, you have your best team you're pulling together. But in this case, we have expert panels, we have public comments, and so people provide all kinds of great feedback, and we really, really appreciate all of that and take everything seriously. And somebody says, what about this? What about that? We analyze it the next day if we can. So I think with that, I just wanted to acknowledge we have a great interdisciplinary team that I get to work with. And so there's a few people here. Molly Marino is here, who works on the project. But we have a great team, CMS leadership. Tara McMullen is our lead. Alan Levitt is our medical officer. And they're both very engaged and very, very supportive of trying our best to make these measures as good as they can be. And then project leadership, Charlene Van is our CMS project officer, and Laura Smith and Lori Coots are the RTI leaders. So with that, I think I'm going to step over and let Vince take over.
Okay, thank you very much. Okay, so we have about 10 or 15 minutes for questions, and the floor is open, and I can't see very well because the lights are really bright, so I'm going to ask somebody to manage the questioning from out there. But anybody on either of these topics or just general about quality metrics? Please, please, we're up here. So Pedro.
Pedro Gonzalo from Brown University. I have a question for Amy. In these charts that you were that you were showing, and we had copies, paper copies around, all these measures that you provide, are they all risk adjusted, or they are?
Yes, each one of them. Again, we take the top 3 risk adjusters that we identified: function, admission function, the diagnosis, which is matched to an impairment group, and medical complexity. And then we simply select the matched patient population from the best practice, the top 20%. So we're actually taking a matched set from a gold standard. And that is what we place in front of the clinicians.
But if, the best practices may be unattainable for many of them?
What we found, very good question, and sometimes I kick things out too quickly. We actually went back and we looked at our skilled nursing facilities, and because we wanted to make sure that it was attainable. You never want to set something that nobody can make the A+, right? And when we looked at all of our skilled nursing facilities, a nice little bell-shaped curve arrived, and we had some A+s and we had some C's and some D's and F's. But most of ours were B's and C's, so each one of them had an opportunity to be able to improve, either on efficiencies. And when you take the 3 components of length of stay, your discharge of function, and your therapy utilization, you merge that with, we also looked at, or on that same dashboard, is discharge back to the hospital and also discharge to the community. We pull all those together, and that's what tells our story. That's where we know what that SNF needs to do in order for them to become part of our best practice. Yeah.
Next. Oh, Joe, go ahead.
Just one quick question to Ann. So these GG sections, we've had them in the MDS. Is that the same that you've been working with then, or?
Yep, this is the section GG data, yep. Yeah, so currently on the MDS, like right today, there's just the selected group based on the process measure. So there's like 3 self-care activities. And October 1, 2018, the larger set of items will become available.
Okay. In the back, Amit, is that you?
Yes.
Okay.
Amit from Brown University. So I have one question to Amy. So have you looked Medicare Advantage population in your data set and notice any upcoding or differences in risk adjustment in that
For which population?
Medicare Advantage.
Medicare
MA.
Advantage?
No, for the MA, because we have our clinicians are out in the field, and also for much of our MA, we do the authorizations for it. And so, no, the opportunity for upcoding, we're just in the SNF. We don't do Med B. We're only doing Med A. So we do not see that we have any upcoding whatsoever. Now, in the BPCI, if you're talking about rugs and BPCI, I think Dr. DeYoung explained that on BPCI, they still are paid on fee-for-service levels. We only have an influence. We can only go in and say, this is what we would suggest that you do based upon the data that we have here. Even with BPCI, though, I'm pleased to say I don't get the dramatic improvement that you see there, but we have seen some significant improvement in BPCI. Once again, looking at their RUGS rates and looking at their length of stay and not compromising their outcome. If that's what you mean by upcoding.
Yeah.
Okay. Yes. We're very careful about that.
So, and when we will have care data tool finally available for researchers to use?
When is the care data going to be available? So the Section GG data, so I guess the IRF-PI data from 2016, whenever that's available, the first quarter would be included
We have it.
Yeah, well, there you go. It's out.
We have it. So, just Ann, because there's not somebody else, but please think of other questions. I have a question for you about, it's my understanding, this might be inside baseball at CMS, that the reason the wholesale instruments have not been restructured to accommodate the care tool items is because the payment people need to keep with the same elements for RUG or home health, the home health groups, et cetera. Has there been any effort to crosswalk or look at what the implications might be for a RUG class versus based on MDS items versus a GG item, or is that possible?
So, I mean, I can't speak for payment. You know, we are analyzing the data. Certainly, for example, on IRF-PI, we are doing analyses of those data. In fact, I mean, we did that as part of the PAC-PRD. We had the exact same patients. Obviously, we had FIM data, and we had you know, the care tool section GG function data, and we did cross tabulations. We actually have published that. It's on the CMS website, and we gave the background on where we thought they would overlap, and we basically in our crosstab kind of, I think we did gray for the cells where we expected overlap. There are obviously differences in terms of how the items are defined that make a difference. So just one quick example, for eating, in the FIM, I believe they allow administration of G-tube feedings to be coded on the FIM. On the section GG care items, we basically say the activity didn't occur. We require that it's eating by mouth. And so we do see that those differences happen. We have done cross-tabulations on data where we obviously expect things to overlap. We have also done analyses where we look at the overlap, for example, with the FIM walking item and the walk 10 feet item, and we do see, as you would expect, a lot more variability on the 10 feet, whereas they're more clustered together on the 150 feet item. And so, it makes us think, are we able to pick up differences that we wouldn't otherwise be able to see? So we have been doing that with the IRF-PI data, and we've started to do it with the MDS data. There's a limited number of items right now on MDS, but there'll be a few more in the future.
Okay. Other questions? Yes, ma'am.
Thank you all for the presentation. Question about the outcome measures, and hopefully you can answer this. I know that with the discharge, there's going to be a risk standardized expected discharge score. So can you give us any insight into how that discharge score is being calculated? And is it going to be facility specific, or will it be state or national specific?
Sure. That's a great question. So the risk adjustment, basically, we use the national data to create regression coefficients and intercept and regression coefficients for each of our covariates, each of our risk adjusters. And we have the primary diagnosis. So just as, I guess, a quick example, I think, let's see, we have stroke as a diagnosis, and our reference category is patients with hip replacements, hip and knee replacements. And so we find that patients who've experienced a stroke have, in general, I think it was 10 units less on average in the mobility discharge score and the change score also. And so basically for each patient stay, we apply the regression coefficients to the actual data. So if somebody had a hip replacement, there would be no adjustment for diagnosis. If somebody experienced a stroke as their primary diagnosis, we would say, minus 10 as part of that application of the regression coefficients, and we would calculate the expected score by applying all the regression coefficients in the intercept that are appropriate for that person based on their comorbidities, their age, their primary diagnosis. And so that comes up with an expected score. Does that help?
Yes, can I ask a follow-up then?
Yeah.
So it sounds like then it's almost done on an individual basis at each facility. Would that be correct?
Well, we create the regression model, so the coefficients from that are from the national data.
Okay.
For within each setting. So, there'll be a sniff model. Okay. The IRF regression coefficients, I believe, are actually already out there. There is what's called a QM user's manual, and this has in detail how to calculate the measures, all the exclusion criteria, and it has the regression coefficients, and it basically walks you through the process of how you would take your individual records and apply the regression coefficients. Okay. It's there for pressure ulcer too.
Last question then. So for IRF, you have maybe 13 different categories that you apply based on?
For the primary diagnosis, yeah.
Do you know how many you're going to have for SNF?
It's the same groups.
Will be the same?
Yeah. So as part of the MDS 2018,
right,
there's a new Section I item
question about
that is basically
primary functional?
Primary diagnosis.
Okay.
So this, I think, is kind of new to SNFs. You'll be able to know, was the person admitted for care following a stroke, traumatic brain injury, non-traumatic brain injuries, traumatic spinal cord injury, non-traumatic hip replacement. So that was part of the function measure risk adjustment that's now going to be added to the MDS.
Anyone else? So then, is there, one more question, Ann? Is there an intention to come up with an outcome model that spans the settings so that you would say, let's put together all of the data for all of these people across setting and then do that?
Yeah, I'm not sure I can speak about that, but I think, when the data are available for researchers, the researchers can absolutely do that, right? So, you can, and I think, to your point earlier about how you aggregate everything together and maybe, can you interpret that? The opportunity to do studies and look at patients who have experienced a stroke and how they do in all 4 settings and stratify based on severity or, that will be available for researchers.
And just so you know, that's kind of a goal of those of us in the field, is to be able to say, given the CVA at this point in time, for this specific CVA with these certain characteristics, is it going to be not only financially best, but also functionally and all other ways, to send them first to an IRF and then to a SNF, or first to a SNF, then to an IRF, or straight home. But that's our goal.
Any other questions from anyone in the audience? And if not, please join me in thanking very much our presenters.